so much, Corey. I really love coming to this conference. It's great coming to New York. Thank you, everybody, for being here for my talk. And I am sort of known for speaking rather quickly, and Corey keeps sort of upping the ante on me by giving me more and more to cover in shorter periods of time. So today I'm covering three rather disparate diseases. These are my disclosures. So Corey called this the thoracic wilds, and I consider these zebras of the chest. So I was trying to think, how am I going to cover this in 20 minutes? How am I going to cover these different entities? And I thought one way to do this would be to compare and contrast. What do they have in common, and how are they different? Well, what they have in common is that they're all quite rare. So I have the incidence for all these here. So Thymoma, 0.13 to 0.15 annual incidence per 100,000. Thymic carcinomas is supposed to be exceedingly rare, less than 1 to 5% of all the thymic epithelial tumors. So carcinoids of the lung, 1.35 annual incidence per 100,000. Much more commonly, these are considered well-differentiated neuroendocrine carcinomas, and we more commonly see these in the GI tract, and well-differentiated neuroendocrine tumors in the lung represent about 30% of all NETs. And then large cell neuroendocrine of the lung is a subgroup of non-small cell lung cancer that represents about 2 to 3% of resected tumors. So they're all rare. The primary treatment for all these entities is surgery, if patients are surgical candidates. 5-year survival is very different depending on which of these diseases you have. There's a relatively good prognosis for thymomas, not so much for thymic carcinomas, and I'll discuss the distinction later. Typical carcinoids tend to do quite well with 87 to 100% 5-year survival. Not so well if you've got atypical carcinoid. And then large cell neuroendocrine tumors of the lung have a very poor prognosis. Chemotherapy responsiveness, thymomas are actually quite chemotherapy responsive, thymic carcinomas less so. Typical and atypical carcinoids are not very responsive to traditional cytotoxic chemotherapy, and large cell neuroendocrines are about as responsive as non-small cells in general, less so than small cell for sure. Another thing these all have in common is that there are not any prospective randomized studies to guide us in determining what is the standard of care. So starting with thymic epithelial tumors, these are neoplasms derived from thymic epithelial cells. There are lymphocyte elements that may be present and may even predominate, but the overall cancer are the epithelial tumors, and my timer never actually started, so I have no idea how much time I have. Okay, so we'll try to do the best of it. Other tumors that can occur in the anterior mediastinum, which is where thymic epithelial tumors occur, lymphomas and germ cell tumors, and carcinoid tumors may arise within the thymus, but these are not considered thymic epithelial tumors. Thymic epithelial tumors are the most common cause of anterior mediastinal masses in adults. Both sexes are equally affected, most commonly in the 5th and 6th decades. In these patients, a third present asymptomatically and are found on screening, a third have localized symptoms, and a third present with Myasthenia Gravis. These patients do seem to have an increased incidence of secondary malignancies, probably related to the fact that the thymus is important in the immune system. So there are different types of thymomas. These are determined by the WHO classification, and they are A through B3. They are related to which part of the normal thymus they look like. So type A thymomas look very much like the normal thymus, the medulla of the normal thymus. A, B are mixed. Type B look like the normal thymic cortex, and then type B tend to de-differentiate. So you can have B1 tumors are look the most like the normal cortex, and then B3 is the less differentiated appearing tumors, and there are little snippets of what these look like over here. So the staging system, the classic staging system is the Musoka staging system. Stage 1, it is completely encapsulated. Stage 2, there is invasion through the capsule, into or through the capsule. Stage 3 is when the thymic tumors are invading into neighboring organs. And stage 4, 4A, pleural pericardial dissemination, and 4B, lymphangitic or hematologic metastases. So that is the traditional staging system. There is a new proposed staging system by the International Thymic Malignancy Interest Group, and that's shown here. And the differences here are that the stage 1 encompasses stage 1 and 2 Musoka stage tumors, and the stage 3 Musoka stages are split between stage 2 and stage 3, with stage 2 being those that were just invading into the pericardium, which tend to have a better prognosis. So thymomas that are earlier stage have a better prognosis, and that's demonstrated here. And you can sort of see why in the new staging system that the proposal is to put stage 1 and 2s together because they have a similar prognosis, worse for stage 3 or stage 4. And then histology counts as well. So subtype A tumors have the best prognosis, but are also not terribly common. And then the worst prognosis are thymic carcinomas. These used to be within the thymoma categorization as type C, but are now a separate entity. So thymoma or thymic carcinoma, what's the difference? It's based on their histologic appearance. Thymomas, actually under the microscope, are quite bland appearing, but it's important to know that any thymoma can still be invasive or metastatic. Thymic carcinomas look like cancers under the microscope, and there are multiple different subtypes that I've listed here. The most common subtype is squamous cell carcinoma. So there are several paraneoplastic disorders that are associated with thymomas, and this is important for getting the question when it's re-asked right. So myasthenia gravis, 30 to 50% of patients with thymoma will have myasthenia gravis, but there are other immune paraneoplastic syndromes associated with it, including pure red cell aplasia and hypogammaglobulinemia, as well as SLE, but those are less common. Myasthenia gravis, what is it? It's an antibody-mediated T-cell-dependent autoimmune attack against the acetylcholine receptors in the postsynaptic neuromuscular junction. What does that mean? What do patients experience? They have weakness in their ocular, bulbar, limb, and respiratory muscles. Patients who are going to surgery can experience a myasthenic crisis. And for that reason, any patient with thymoma or anyone who is suspected of having myasthenia should certainly get a neurology consultation before going to surgery. So while 30 to 50% of patients with thymoma have myasthenia gravis, about 10 to 15% of patients who have myasthenia gravis will have an underlying thymoma discovered. So basic principles of thymoma: it's important to get complete surgical resection. Prognosis is excellent for early stage disease. Recurrences can, however, occur several years later, so prolonged follow-up is needed. And by several years, I mean even decades later, these patients can recur. When thymomas recur, they tend to metastasize to the pleural as drop metastases. The survival is better for patients who undergo a total resection, for those who have subtotal resections or those who are inoperable. One very controversial area is whether patients with resected thymomas should undergo postoperative radiation. I have the current NCCN guidelines listed for you. For stage 1 tumors that are completely resected, R0 resection, there is no recommendation for postoperative radiation therapy. For incomplete resections, it's clear that postoperative radiation therapy is a good idea. What's less clear for stages 2 through 4 that are completely resected, postoperative radiation is considered a category 2B recommendation. Part of the reason for that is this meta-analysis, which looked at all the retrospective studies, and remember, all these studies are retrospective, looking at the benefit of postoperative thoracic radiation. And the white boxes are stage 2, gray are stage 2 and 3, black are stage 3 only, and it did not show a clear benefit in the ability of postoperative radiation to reduce the local recurrence, reduce recurrence rates. There has been, since that publication, though, a larger series from the Japanese of database of 2,385 patients. Once again, in the patients with thymoma, there was not a clear benefit seen at stage 2 or stage 3 for postoperative radiation. There was, however, a benefit in those patients who had thymic carcinoma, and this actually achieved statistical significance for those patients with stage 3 thymic carcinoma. But really, the whole story isn't completely clear in thymoma. This is a SEER analysis of postoperative radiation in patients with stage 3 resected thymoma, and it actually showed that those who got postoperative radiation, which, remember, if this is a retrospective look, you would think those would be the higher risk patients, but indeed they had an improved disease-free survival rate. There was not a difference in terms of overall survival, but in cancer-specific survival, this was statistically better for those patients who got postoperative radiation. So it is still reasonable to consider in patients with thymoma postoperative radiation. Less controversial is the concept of chemotherapy. Why might we use it in patients with thymic tumors? Well, to palliate those with advanced disease, to improve outcomes for patients with locally advanced disease where you may be able to convert them to surgical, and then to improve the efficacy of definitive radiation. Here's a list of chemotherapy combinations that have been shown to be useful in thymic tumors. The most successful regimens have used adriamycin and cisplatin, and those are shown here with response rates from 50 to 90%. There was an ECOG study looking at carboplatin and paclitaxel, and while the earlier studies tended to just lump the thymic carcinomas in with the thymomas, with the thymic carcinomas representing a small percentage, this study actually broke out those patients with thymoma, and they had a 43% response rate, which the authors considered not promising relative to what we had seen in the older adriamycin-based regimens. In thymic carcinoma, the response rate was 22%. There has also been a retrospective Japanese study looking at carboplatin paclitaxel only in thymic carcinoma, only 12 patients, but it did have a response rate of 25%, and these were previously treated patients. So if you actually look in the NCCN guidelines, it says that carboplatin and paclitaxel is the preferred regimens for thymic carcinoma. So one thing that chemotherapy can do is convert patients who are not initially felt to be operable and turn them into operable patients. And this is a series of studies showing that strategy. These are the chemotherapy regimens that they received. The response rate in these patients is even better. These are patients without advanced disease, but just localized disease. And many of these patients, a high percentage of these patients, were able to go on and get a complete resection. Some even had a pathologic CR, and there were some durable long-term responders in this population. So for patients who cannot get surgery initially, induction chemotherapy is reasonable to consider. This is an ECOG study that looked at patients with not initially resectable disease, but not distant metastatic disease, and treated them with 2 to 4 cycles of cisplatin, adriamycin, and Cytoxan chemotherapy. And in this case, that was followed by 54 gray of radiation. The response to chemotherapy was quite good, and the 5-year failure-free survival rate was 54%. So this is also a reasonable strategy of chemotherapy followed by radiation for those patients who don't convert to operable. For relapsed thymoma, there are lots of different things you can use. Pemetrexed has shown good responses in thymoma, not so much in thymic carcinoma. Patients who have Octrea scan-positive tumors can respond to octreotide. Sunitinib has shown a reasonable response rate in thymic carcinoma, 26% in a phase 2 study. mTOR inhibitors in a very small group of 8 patients showed responses about a third. And there's a publication showing the combination of gemcitabine and capecitabine in previously treated patients had a reasonable response rate. So this is a treatment algorithm that one could use for thymoma. If you have a tumor in the anterior mediastinum that looks like it might be a thymoma, you don't have to do a biopsy. You can just take it out surgically. And if no invasion is present, lifelong follow-up. If invasion is present, consider postoperative radiation. If a patient is not operable, then you look to see is the tumor localized. You want to get a biopsy, avoid the pleural space, which can lead to seeding. Chemotherapy then is a reasonable first strategy, and you may be able to follow that with surgery. And if they're not a surgical candidate, then radiation. If they have distant metastatic disease, then chemotherapy alone. So moving away from thymomas now to neuroendocrine tumors of the lung. This is another graph just showing the different types of neuroendocrine tumors that I'm going to be talking about, typical and atypical carcinoid and large cell, and how this compares to small cell. So for percentage of lung tumors, carcinoids are relatively rare, as are large cell neuroendocrines, particularly relative to small cell, which makes up about 15 to 20% of lung cancers. Immunohistochemical staining, these are neuroendocrine tumors, and the reason they are is because they stain for chromogranin, synaptophysin, and NCAM. The size of the cells determines the difference, so small cells are small, large cells are relatively large, whereas carcinoids can be small to medium. Amount of cytoplasm distinguishes these tumors. The mitotic rate, this is what really distinguishes the high-grade neuroendocrine tumors, which are small cell and large cell and have a mitotic rate of greater than 10 or a Ki-67 of 20%, which is much less than 2 or 3% for typical carcinoids and intermediate for atypical carcinoids. Association with smoking, clear for small cell and large cell neuroendocrine, not so clear for typical carcinoid, maybe with atypical carcinoids. Small cells tend to be central, the other ones are peripheral. Distant metastases at diagnosis, incredibly common for small cell, not certainly uncommon for large cell neuroendocrine, less seen for the carcinoid tumors. Chemotherapy response rates, best for small cell lung cancer, not so great for large cell neuroendocrine, comes in about 40%, and really not good at all for the carcinoid tumors. Surgery, yes, for either the large cell or the carcinoids, but not usually for small cell. And then PCI has only been established for small cell and not the other histologies. So this is examples of what a small cell looks like. You see the small cells with lots of crush artifact. Here's a large cell neuroendocrine tumor. And this I really can't. This is a typical versus atypical carcinoid. So now carcinoid tumors. They derive from the enterochromaffin or Purkinje cells. They can occur in the foregut, midgut, or the hindgut. There has been an increasing incidence in the past decade, but that might just be because more scans are leading to an increased detection rate. These are found incidentally in 0.5 to 1% of all autopsies, usually in the small intestine. About 1/3 of these occur primarily in the lung. Most of these are sporadic, but there is an association with MEN1. There are associated paraneoplastic syndromes. Something else this have in common with thymomas. We've got the secretion of vasoactive peptides like serotonin or 5-HIAA is the most common, and usually that's seen in the midgut tumors. This can cause carcinoid syndrome, diarrhea, flushing, and wheezing. Carcinoid crisis can be life-threatening if a patient receives anesthesia. It's treated with hydration and IV octreotide. And then these patients late in the game can get carcinoid heart disease with valvular lesions, and occurs in 20 to 70% of those patients with metastatic disease. You can monitor these patients with blood or urine markers. There's urinary 5-HIAA. This is a breakdown product of serotonin. It has 100% specificity, but the sensitivity is only 35%. You can also get a platelet serotonin level, but this is able to detect smaller amounts of serotonin, but can max out on your ability to, so you can't really distinguish how much there is. Chromogranin A is useful to track, a useful tumor marker in patients with carcinoids. Chromogranin A is present in the chromaffin granules of neuroendocrine cells. It doesn't have as high a specificity as 5-HIAA, but it has a higher sensitivity and does tend to correlate with tumor burden. There are different ways to image these patients. An octrea scan will image patients who have tumors that have somatostatin receptors 2 or 5, 80 to 90% sensitivity, and is predictive of response to octreotide. There's also the option of MIBG scanning. MIBG is an analog of amine precursor taken up by the chromaffin cells. Bone scan can look for bone mets. PET scans may not be useful in looking at patients with carcinoid because these tend to be low metabolic tumors that may not show up very well. So octreotide is an analog of somatostatin, which interferes with the release of neurotransmitters through the activation of membrane receptors, has a short half-life, but fortunately, there is a long-acting version that you only need to give once every 3 to 4 weeks. Patients with carcinoid syndrome have a symptomatic response 80% of the time with these agents. Both long-acting octreotide and lanreotide have been associated with improved progression-free survival relative to placebo in well-differentiated gastroenteropancreatic neuroendocrine tumors. So this was not done specifically, these studies in patients with lung neuroendocrine tumors, but many of us extrapolate and treat these patients with either octreotide or lanreotide. So for further extrapolation, because most studies of treatments have been done in the GI primaries, streptozocin and doxorubicin initially showed promise in patients with pancreatic NETs with a response rate of 69%, but this really has not been able to be reproduced in other studies, and most people don't use this very often. Sunitinib has shown a progression-free survival advantage in a phase 3 study in GI NETs with a hazard ratio of 0.41 that was statistically significant. The response rate was pretty low, though, at only 9%. And capecitabine and temozolomide has also shown benefit in a phase 2 study with a response rate of 43%. In those patients, specifically with carcinoid, the response rate was 41%, and it does seem that this more traditional cytotoxic chemotherapy approach works better in those patients with a higher Ki-67 rate. So there is the most randomized data now for Everolimus, which has been evaluated in the RADIANT studies that have looked at different types of tumors in different types of settings. RADIANT 2 showed a progression-free survival advantage in patients who had carcinoid syndrome who were treated with octreotide plus or minus Everolimus, 429 patients. Between 5 and 15%, depending on which arm you looked at, actually had lung primaries in this study. RADIANT 3 was only in pancreatic neuroendocrine tumors and again was Everolimus 10 milligrams per day, and also showed a highly significant improvement in progression-free survival from 4.6 to 11 months. And then just presented at ESMO was RADIANT 4, which was Everolimus 10 milligrams versus placebo in non-functioning neuroendocrine tumors of the GI tract or the lung. Lung represented about 30% of these tumors, and again showed a dramatic improvement in progression-free survival. There are lots of other treatments that can be used for carcinoids, liver-directed therapies such as chemoembolization or radioembolization, targeted radionuclide therapy with MIBG, or peptide receptor radiotargeted therapy or PRRT. This has been done for a while in Europe, and now there's a study going on in Houston. This does have the downside of potential renal toxicity. Very little time left. I'm going on to large cell neuroendocrine tumor, but fortunately, if you look at the NCCN guidelines for neuroendocrine tumors of the lung, it just tells you that you can do the same darn thing for high-grade neuroendocrine tumors or large cell neuroendocrine tumors that you can do for non-small cell lung cancer. So good, so I can stop here. Not quite. So there has been an analysis looking at which chemotherapies tend to work best, whether those for small cell like platinum and etoposide or irinotecan versus those we traditionally use for non-small cell work better. And then this analysis, the small cell regimens actually work better in terms of progression-free and overall survival. So these, even though these tumors don't act quite like small cell, you don't give them PCI, they're not as chemoresponsive, they probably are better treated with the chemotherapy regimens used for small cell. And these tumors do have a worse prognosis, so there's a concern that even stage 1 disease that's resected should be treated with adjuvant chemotherapy. And there was this study that showed that patients who got platinum-based adjuvant chemotherapy after surgery did better than those who didn't, but just presented at a conference this past year was a larger study. Again, this was retrospective, 234 patients, of whom 29% of them received adjuvant chemotherapy, and they did not do better with adjuvant chemotherapy relative to those who did not get adjuvant therapy. So there really isn't any data yet showing that there is a way to differentially treat large cell neuroendocrine tumors in terms of either giving them chemotherapy for an earlier stage than you normally would for non-small cell or not. I don't think this tells us that we shouldn't be doing it either. There is a phase 3 clinical trial ongoing of cisplatin and irinotecan versus etoposide. It's going on in Japan as we speak. So, and that's everything.